much. I'm wearing my other cap now as an immunologist. I'd like to just review briefly some principle of vaccination to give you an update of what we think we did good and what is the road that we have to do from now to really achieve some clinical efficacy. So vaccine has been very attractive for melanoma at a time where no classical therapy were working, so that's explains why a lot of effort has been put in the vaccine and study of immunity, especially in melanoma, with no chemotherapy, as you have known, was working, so the field was pretty empty. And there was also some evidence that patients with melanoma can develop immune response to tumor, and we know that a small fraction of patients can spontaneously get rid of their tumor because they develop immune response. So this was important thing that over the past 30 years has pushed people to say maybe vaccine is the way to go. So let's find out. And I'm going to talk about that today. The bottom line is these past 30 years has brought us a lot of information in terms of immune response, know what type of immune cells recognize the tumor, how to improve immune response. So there is a discrepancy between the so-called scientific knowledge, what we know about immune response, how we can do better, and the other important part, meaning what do we achieve in the clinic. And unfortunately, I have to admit, until now, vaccine has been very disappointing in the clinic. Out of a few exceptions, it was a failure. Which is not very encouraging, but and mainly now we are not comparing vaccine against nothing because nothing was working. Now we have seen we have this targeted therapy and a number of therapy which works to give some evidence of response in patients, so which a little bit brings some kind of disappointment. But the message I would like to give today is hope is, taking the knowledge we have, from the knowledge we have, how we can then make them better. And I think what I'm going to try to convey you today is what is the hope, and I hope that the vaccine are going to be a plus. But I think the main message will be that the vaccine will not work alone. They will work in the context of combined therapy. They will have to be combined with other things that are going to make them better. So they're going to be very important as a part of a combinatorial therapy, where other important therapy needs to be added. And that's what I'm going to talk about. So next slide, please. So what is a cancer vaccine? So it's a stimulation of immune cells, which can be T cells and B cells, so white cells in the blood, by antigen. So there's this protein expressed by tumor cells. When we talk about vaccine in melanoma or in cancer, most part of the time we are not talking about vaccine like you get your hepatitis B vaccine or flu vaccine to prevent. We are talking about therapeutic setting, which makes things difficult. I mean, we are talking about patient having already the tumor there, which means a big obstacle to fight. So there's multiple obstacles to that, and I talked about the failure of vaccine, but we know now the scientific knowledge has brought us some knowledge about what impedes the clinical efficacy of this vaccine. So we know that an immune response to work good, you have to have a lot of cells. So the quantity of cells, of immune cells that you're going to stimulate infection is an important parameter. So the quality is also, so these cells, the white cells have to be there in number, but they have to be good enough to kill the tumor cells, so what I call the quality. So there are two processes. So these cells that are killing the tumor have to stay in the blood or go at the tumor site and stay there for a while. They have to go at the tumor site, so you stimulate the cell, the vaccine, in most part of the time I've done subcutaneously, but you want these cells to go to the tumor. And most part, and I'm going to talk about that, we now have knowledge of a number of mechanisms that the tumor uses to fool the immune system. And that's, I think, the most important knowledge. You can have the T cells, you can have a lot of T cells in your blood. These T cells, if you take them in the laboratory and test their capacity to kill the tumor, they will do a great job killing the tumor. But in patients, these cells are there in great number, they can kill, but they don't do the job. And now there is a number, this is the big advance of the field, has been to understand the many mechanisms used by the tumor to fool these T cells. What are the tumor is going to impede these T cells, impede their function, make them dysfunctional, kill them. And there's a number of ways that the tumor can do that. So how to overcome this obstacle to make vaccine work in the clinic? So the antigen format is important. So what type of antigen are we going to use? And optimally, you like to have an antigen that is capable of inducing the so-called CTL, so the cytotoxic T cells that are going to kill the tumor. But these T cells, to stay in the circulation, to persist, they need some help. There's some helper cells, so you would like the vaccine also to stimulate the killer cells, but also the helper cells. And optimally, you like also this antigen to stimulate B cells, antibody, which would be good. What we call an integrated response. All the main component of immune response. Next slide, please. So one important thing is in the vaccine, so you have the antigen that stimulates the T cells, but this antigen needs to be presented to T cells in a special way. So that's we have the so-called antigen-presenting cells that are stimulate T cells that bear the antigen at their surface, but they have to be very activated, and that's what we call adjuvant. The adjuvant have to play an important role in terms of presentation and stimulate the T cells. And there have been a lot of research, done over the past years to try to find potent adjuvant to stimulate potent immune responses. And we did a great job, I think, finding the so-called toll-like receptor ligand. So you may have heard about CpG, now which are already in the clinic. There is a poly-ICLC, and that's what these adjuvants that are clinically available and can be used in patients are doing. So they stimulate the antigen-presenting cells and allow good stimulation of the immune response. So that's in terms of antigen, we did a great job. In terms of finding new adjuvant, we did a great job. And the third component, that's where I think we have to still to be very active and do a major improvement, is finding way to reverse melanoma dysfunction, to try to impede the tumor in fooling the T cell immune response, to breaking this inhibitory pathway. So in terms of tumor antigen, so next slide. So there is some over the past 20, 30 years, we did a lot of so-called antigen discovery, and did a great job finding antigens specifically expressed by tumor cells. And we know that we can produce this peptide, fragment of protein, or the whole protein. We can do that. It's easy to produce, and we have been using that in patients in context of vaccine. So, and we know that using peptide and protein to vaccinate patients is pretty safe. So next. So there is some disadvantage in using peptide and protein. For peptide, they are the fragment of the tumor antigen. So patient has to express some specific, what we call HLA molecule to present the peptide. So a given peptide will not be good for all the patients. You have you have to express some HLA restriction. If you use a protein, you are not restricted with the same elements. We need adjuvants with antigens, so I talked about that, but now I think we did a great job with the CpG and poly-IC. We have very good adjuvants. Next slide. So the adjuvants, and I talked about the CpG poly-IC, they are most part of the time non-toxic. They are available for clinical trial. As I say, they play a role in activate antigen presentation and activate T cells. So we have that in hand. So now, and I think that's the most important thing, is understanding. So when you stimulate immune response, and you manage to have a lot of T cells in patient, and we have very sophisticated way to evaluate that in the patient after vaccination. And so I didn't give you some example. I don't want to go into scientific argument, but we are able to evaluate that. And you vaccinate patients with, let's say, ongoing vaccine at the cancer center with CpG and antigen. We can demonstrate easily that the patient can develop high level of white cells, T cells, capable of recognizing their tumor. And we have many examples of that. But these patients have still progressive disease, and metastatic melanoma that progress. So we have the T cells, they are not capable of doing the job. How this happens? So, and this puts emphasis on the mechanism used by the tumor to fool the immune system. And at tumor site, and this is, let's say, a representation of tumor site, this is a T cell that is capable of recognizing the melanoma cell. So what are the main mechanisms used by the tumor to to fool the immune system. They can produce a number of cytokines, of protein, that are going to dampen T cells. And IL-10, TGF-beta are two of these proteins. So now there is antibody targets, they are being used or are going to be used in the clinic that may be used to decrease this inhibitory protein. We know that melanoma cells also can lose their capability of stimulating the immune system to present the antigen to T cells. So they can lose the HLA molecule, they can lose the antigen. So one way to go around that is, in terms of antigen presentation, is to, some people are proposing to use dendritic cell vaccine, to take the blood of patient, prepare these antigen-presenting cells ex vivo, pulse them with protein and re-inject them, adoptive transfer of dendritic cells to improve a presentation that is effective at the tumor site. So there is also in the tumor microenvironment a number of cells that regulatory or supersede T cells. So they are present at tumor site, and what they do is to dampen immune response. So even if you have the good cells, these cells are going to be there and decrease the function of these cells. So, and we put a lot of efforts trying to find a way. We haven't found the really good ways, but it's still investigation, how to decrease these T cells. Some people are with some type of antibody localizing a specific marker. This is still ongoing. One very promising way, I think I might talk about that, is the evidence of inhibitory receptor, and seems to be an important mechanism of immune suppression at the tumor site. And what it is that the tumor is able to express a number of protein of ligand, and is capable of inducing, making these cells express a number of inhibitory receptors. So you have about PD-1, CTLA4 is one of them, and there is a number of them. So under the pressure of the tumor, this T cells, which is capable of hitting the tumor, is going to express this inhibitory receptor. This inhibitory receptor binds to the ligand expressed by tumor cells. And although these T cells can kill the tumor, basically the engagement of this pathway is going to make these cells dysfunctional, and they're going to die. So they are able to kill, but the tumor is going to engage this pathway and make them die. So they're not going to persist. They can do the job, but they're not going to do for a long time, and the tumor is winning the battle. So this means that it became, as a hypothesis, very important to say, let's inhibit this pathway. And that's what has been done with antibody targeting the CTLA4. What is being done now is antibody targeting the anti-PD-1. So we have us working a lot about another important pathway called TIM3 also. And I think this pathway are being targeted. So the CTLA4 is in the clinic, the PD-1 in the clinic, and at least the TIM3 will be in a couple of years or something going to here very soon. So, and I think that's an important part of the strategy to improve cancer vaccine. Yeah, so that's just to tell you in other terms what I was explaining you. What we like to do with vaccine is stimulate an immune response which looks like the immune response you spontaneously develop when you have a flu. When you have a flu, your cells are infected, you develop T cells, immune cells, that recognize your infected cells. And these cells are very good. They proliferate, they produce a number of cytokines, and they can kill the infected cells. That's the acute infection. And our goal is to try to develop this type of infection. Unfortunately, when we are in the context of a chronic infection, or people with tumor antigen, which is very similar to chronic infection, in the presence of chronic persistence antigen, persistence tumor, high level of tumor in patient, these T cells, they lose their capacity to produce the cytokine or to kill. They become dysfunctional, and these cells that become dysfunctional upregulate this inhibitory receptor, PD-1, CTLA4. That's what happens in patients. That's what this pathway needs to be targeted. Next so that's the final things, and the vision of what would be a good vaccine. So again, in the tumor microenvironment, we have the melanoma cells, we have some antigen-presenting cells, and we have T cells. In fact, the T cells are present in melanoma. So if you take a melanoma under the microscope, examine it, most of the melanoma have T cells present, as part of the diagnosis, they just don't do their job. So what we do with vaccination, we want to stimulate these cytotoxic T cells capable of recognizing the melanoma and killing them. And again, we do a great job. This with using adjuvant and peptide or protein, we are capable of stimulating these T cells. And if you take these T cells and test them in vitro, they will kill the tumor. But again, in patients, they are there, and this is not happening. Why this is not happening? That's what I was explaining you. The tumor expresses some ligand here, some protein, TIM3 or PD-L1, which interact with the receptor expressed by this T cell, exhausted T cells, and this pathway are going to induce the death of these T cells. So how to reverse that? One very promising way is antibody PD-1 and TIM3, for example, but other one may be possible. Combination with vaccine, which are going to block this pathway, allow these cells to kill without being killed and persist. That's, I think, the most promising way to improve vaccine in the future.